Hello everyone, I'm Dr. Vallabh Chawla and today we'll be doing a case report on periapical cystic lesion in the upper anterior region with a history of trauma. Okay, so basically patient came with the chief complaint of swelling in the upper anterior region. Usually in a 2D OPG scan, such type of swellings are usually not visible. So you can see a faint radiolucent appearance in the upper anterior region at the periapical region of 1-1 and 1-2 region. So just to confirm that we took a CBCT scan, a sectional CBCT scan of that specific region. There was some kind of altered bone density in the upper anterior region. So something that was not visible in the OPG, so was clearly seen in a CBCT scan. This is the axial cross section, coronal or the frontal cross section, and the sagittal cross section. The area of chief complaint was 1-1. Okay, so this is 1-1. 1-2. There's history of trauma, so you can see some kind of fracture over here. It's there was long standing history. It was in the past, so the tooth was discolored when seen clinically. So this is a tooth of concern 1-1. As we go towards 1-1, there was a huge periapical cystic lesion seen in the periapex of 1-1. So this is 1-1. We'll just arrange it along the long axis of the tooth. Okay, so as we go along the long axis of the tooth, you can see this is the region of interest as seen it in all three cross sections. You can see this thing in the periapex region of 1-1. This is the crown region as seen in the axial cross sections. As we go towards the root, this is in the middle one-third root region, lower middle one-third root region, and at the root apex region. So there is the internal aspect of the swelling. This round dot seen is nothing but the nasopalatine nerve canal or the incisive canal. Okay, so we can clearly make it out that the lesion is in contact with the nasopalatine nerve canal cortex. There's this faint radiolucent line that separates the nerve from the lesion. It's a fine trabecular pattern, but as we go apically, you can see the faint radiopaque line. It disappears. So definitely, patient has some kind of paresthesia. You can see it in this cross section as well. We'll just delete this. You can see this faint radiopaque line that separates the lesion, but still patient has that feeling of paresthesia. This is tooth of concern 1-1 arranged along the long axis of the tooth. You can see some initial signs of root resorption, but very initial signs of root resorption. But you can clearly make out there is displacement of the root because of the periapical cystic lesion. Always when comparing with the opposite counterpart, this is 2-1 and this is 1-1, so we can easily make out how the tooth roots have been displaced. You can easily check it in the 3D volume as well. So how 2-1 is appearing straight and along the long axis, and 1-1, you can see the roots have been displaced because of the periapical lesion. However, there's no signs of root resorption except in initial apical end. As seen it over in the coronal cross section, we can make it out partially. The lesion, so mesiodistally, it extends from the first quadrant. It is restricted to the first quadrant itself. It starts from the interdental region, between 1-1 and 2-1 midline, and goes till the canine. This is canine, so it goes till the mesial aspect of the canine. So 1-2 is also involved. This is 1-2 periapex, and this is canine, so till the mesial aspect of canine. 2-1 you can see is not affected. However, initial PDL widening may be noted in 2-1 and 2-2. And this is the occlusal aspect as seen in the 3D volume. So this is the occlusal aspect and this is the palatal aspect. The same lesion we can study in smallest cross sections also. So you can see this is the smallest cross sections. This thing you can just check it out. So this is the lesion part, the borders of the lesion, and this is the tooth part just to study the displacement of the tooth. So these are the coronal cross sections which are seen. You can see the nasopalatine nerve canal and the lesion, they are in contact with each other, hence paresthesia is seen. You can always measure the lesion as well. So this is measurement 1 and this is measurement 2. Also to note, this is the labial cortical plate, this is the palatal cortical plate. We can see there is evident thinning and thinning of both labial and the palatal cortical plate because of the marked expansion of the lesion. Similarly, this lesion can be studied in axial cross sections also. This is the occlusal aspect. As we go down, this is the root region. You can see because of the expansile nature of the lesion, this is the expansile nature of the lesion. You can see it is expanding both labially and palatally as well. So you can make it out there is thinning of the cortices, and also there is evident thinning of the nasal flow. This is the nasal flow, so nasal flow is also thinned out. This is the anterior nasal spine. Okay, so this is the anterior nasal spine. It appears normal, but in the 1-1 region you can just see there is evident partial thinning of the anterior nasal spine as well because of the expansile nature. However, there is no signs of perforation or erosion, just initial thinning is noted, evident thinning is noted, but If left untreated, definitely there will be some kind of perforation that will be starting from here or here. So it is necessary to treat such kind of lesions. So as per radiographic diagnosis, such lesions are usually periapical cystic lesion based on the history of trauma, and always for accurate diagnosis, another test is required, like FNAC test, to check the contents of the lesion, the exudate or any cystic fluid which is there with the histopathological findings. Okay, so you can just make it out. This is XYZ view and just check the lesion in 3D volume. Okay. Okay. Thank you so much.